What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my cardiology playlist. In previous videos, we've talked about angina and myocardial infarction. We discussed the types of shock, such as cardiogenic shock, obstructive shock, hypovolemic shock, septic shock, anaphylactic shock, and neurogenic shock. We talked about cyanotic congenital heart diseases and acyanotic congenital heart diseases. We discussed rheumatic fever and infective endocarditis, dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy, acute fibrinous pericarditis and constrictive pericarditis, pericardial effusion, and cardiac tamponade. And we talked about the different types of cardiac arrhythmias. And in the last series, we started talking about valvular heart diseases, such as aortic stenosis, aortic regurg, and today's topic, mitral stenosis, when my mitral valve is narrow. Recall that the mitral valve is the valve between the left atrium and the left ventricle. It is one of the atrioventricular valves because it lies between the atrium and the ventricle. What causes mitral stenosis? What are the symptoms? How can we diagnose it? And how can we treat it? Let's find out. Click the like button, click the subscribe button because my face is already flushing, which is one of the signs of mitral stenosis. This is my cardiology playlist. It has cardiac anatomy, physiology, pharmacology, and pathology. Remember that your heart has 4 chambers: right atrium, right ventricle, left atrium, and left ventricle. Where does the left atrium receive blood from? It receives blood from the pulmonary veins, which receive blood from your lungs, both of them. The right lung contributes 2 pulmonary veins, and the left lung contributes 2 pulmonary veins for a total of 4 pulmonary veins. This is oxygenated blood returning from the lungs to the heart, to the left atrium of the heart to be specific. And then we're going to leave the left atrium through the mitral valve to end up in the left ventricle. Why do we call the mitral valve mitral? Because it looks like la mitre. What is la mitre? It is a special religious hat in Catholicism. But what does that have to do with the mitral valve? Well, just like la mitre, the mitral valve contains 2 cusps, not 3 cusps. Every other valve in the heart has 3 cusps, except for the mitral valve, which has 2 cusps only. And that's why the mitral valve is also known as the bicuspid valve. Bi means 2, cuspid means cusp. If you wish to see more videos like this in the future, drop a heart emoji in the comments. Between the right atrium and the right ventricle, we have the tricuspid valve. Between the left atrium and the left ventricle, there is the mitral valve. Between the left ventricle and the aorta, there is the aortic valve. And between the right ventricle and the pulmonary artery, we have the pulmonic valve. When I say mitral stenosis, what does that imply? It implies that the mitral valve is narrower than normal. And when the valve is narrow, i.e. stenotic, this hinders and prevents the forward flow of blood, unlike with regurgitating murmurs, which allow backward flow of blood. So in total, we have 4 heart valves: aortic, mitral, pulmonic, tricuspid. These ones are on the right, these ones are on the left. The mitral and the tricuspid are called atrioventricular valves because they lie between the atria and the ventricles, whereas the aortic and the pulmonic valves are called the semilunar valves. Each one of these valves can have one of 2 diseases: stenosis versus regurg. Stenosis is difficulty at opening, but regurgitation is difficulty at closing. Today we're talking about mitral stenosis, difficulty at opening. When is the mitral valve supposed to open? The mitral valve is supposed to open during diastole to allow the blood to flow from the left atrium to the left ventricle. And because the mitral valve is supposed to open during diastole, therefore mitral stenosis is a diastolic murmur. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. These are the 4 chambers of the heart. Let me ask you a question. Which of them is the most anterior chamber? The answer is the right ventricle is the most anterior. Okay. However, what is the most posterior chamber? The answer is it's the left atrium. Here's a quick anatomy review. This is the thorax. Here is anterior. This is posterior. This is superior. This is inferior. This is the sternum. This is the diaphragm. This is the thorax. This is the abdomen. This is the heart. What's the most anterior chamber? Right ventricle. What's the most posterior chamber? Left atrium, which is related to the aorta, the trachea and the bronchi, the esophagus, sarcophagus, and the left recurrent laryngeal nerve, which is a branch of the left vagus that wraps around the ligamentum arteriosum, which is a ligament, formerly an artery, between the aorta and the pulmonary artery. Why is this important? Because in mitral stenosis, the mitral valve is narrow. Therefore, the poor left atrium will have to contract harder, and harder to overcome this resistance. Why is this? Because when I have mitral stenosis, what's going to happen to the radius of the mitral valve? It will decrease. And when radius decreases, according to this beautiful equation, if anyone remembers, it looked like this. Oh, that was the Poiseuille equation. Notice the inverse correlation between radius and resistance. So when the valve gets narrower, the radius decreases, and therefore the resistance increases. Therefore, this poor left atrium has to pump harder and contract harder to overcome this high resistance caused by the stenotic mitral valve. As a result, the left atrium gets larger. We call this left atrial enlargement. As the left atrium gets larger and larger and larger, it is going to compress my esophagus, leading to dysphagia or difficulty swallowing. The left atrium will compress the left recurrent laryngeal nerve, causing dysphonia, which is hoarseness of voice. It might even compress the main stem bronchi and cause cough and dyspnea. See, anatomy makes so much sense once you understand what the French toast you're talking about. Here is another view of the thorax. This is anterior, here is posterior. This is the left side and this is the right side. Imagine that you slit my throat and you're looking down my neck. Here's the heart, here's the sternum. Here's the body of the thoracic vertebra. This is the thoracic aorta. This is the esophagus. And these are the main stem bronchi. The most posterior chamber of the heart is the left atrium. As the left atrium gets bigger and bigger and bigger, it compresses the main stem bronchi, causing dyspnea and cough. It is going to compress the esophagus, causing dysphagia, and it's going to compress the recurrent laryngeal nerve, causing dysphonia. If you want more medicosis anatomy in your life, check out my anatomy playlist here on YouTube. It has comprehensive review videos for all of the anatomy branches, including anatomy of the head and neck, upper extremities, lower extremities, anatomy of the thorax, the abdomen, the pelvis and perineum, neuroanatomy, and embryology. Each anatomy subject is covered in 3 videos. For example, anatomy of the thorax has part 1 called quick review, part 2 ultimate review, and part 3 clinically oriented anatomy of the thorax, and then we repeat the same thing for every subject. Does anyone remember the Ferko's triad from pathology? Yes. The Ferko's triad tells me what? Tells me whether I have high or low risk of coagulation, meaning thrombosis. These risk factors include endothelial damage, blood stasis, and hypercoagulability. Mitral stenosis is characterized by blood stasis, as we will discuss shortly. To understand everything you need to know about mitral stenosis, get a piece of paper and doodle with medicosis. You're gonna need 2 colors, one blue and one red. So, with the blue color, draw the right atrium and the right ventricle. Why blue? Because these chambers have deoxygenated blood. And then with the red color, you draw the left atrium and the left ventricle like this. That's just amazing. Then what? Next, bring a third color and draw the septum in between. And the mitral valve is here. Okay, what's next? Well, in mitral stenosis, the mitral valve is narrow. Okay, the valve is narrow. Therefore what? If it's narrow, it means the radius is low and the resistance is high, which means the left atrium has to push harder and harder and harder and harder until it enlarges and enlarges and enlarges. This is left atrial enlargement. And since the left atrium is the most posterior chamber in the heart, it is going to compress the esophagus, causing dysphagia. It is going to compress the recurrent laryngeal nerve, causing dysphonia. It might even compress the lower part of the trachea and the main stem bronchi, leading to cough, dyspnea, etc. Moreover, don't forget that the heart is full of specialized muscle fibers that conduct electricity. That's the story of the cardiac action potential. So as the left atrium gets bigger and bigger and bigger, this can disrupt those fibers that conduct electricity, and this can be arrhythmogenic. This can lead to atrial fibrillation in the heart. And of course, you know that atrial fibrillation, as we have discussed in a previous video on this topic, see my cardiology playlist, that atrial fibrillation is a very, very weak left atrium. Instead of pumping blood, it is tickling blood. This is a bunch of nonsense. So therefore what? Therefore, I'm not going to be able to push blood. So this will lead to blood stasis. Blood stasis is one of the components of the Ferko's triad, which will cause what? Which will cause thrombosis. If a thrombus forms in the left atrium, we call it thrombus. Then, if it dislodges and goes somewhere else, we're going to call it an embolus now. This embolus can travel from left atrium to left ventricle, then from left ventricle to the aorta, and then from the aorta, it can land up anywhere in the body, including the brain. And if it enters the brain, what's going to happen? It can lead to a stroke. Is it an ischemic stroke or a hemorrhagic stroke? The answer is ischemic stroke. Is it a thrombotic stroke or an embolic stroke? Since the clot did not originate in the brain, but originated in the heart instead, we're going to call it embolic stroke. Oh my goodness, all of this can happen in mitral stenosis, but wait, there is more. As the left atrium gets weak from the atrial fibrillation, blood stasis will ensue. This blood stasis starts in the left atrium. Then it's going to affect the 4 pulmonary veins, so the blood will accumulate there as well. Then it's going to affect both of your lungs, so fluid is going to accumulate there as well, which can lead to all of the following. It can lead to cough that is wet and productive, not dry. It can lead to dyspnea, which is shortness of breath. That's another cause of cough and dyspnea. And it can lead to orthopnea, which means if I lie down flat in bed, I get short of breath. Therefore, I have to be more upright and prop my head up on several pillows. The greater the number of pillows, the greater the severity of the disease. See, your average cardiologist dreamed of changing the world when he or she was young. Now look at you, you're just counting pillows. And don't get me started on gastroenterologists. They are working with poop all day long. Or pathologists who are working with all kinds of body excrements. For a pathologist, life is not pink and rosy. In fact, the only pink that you see is under the microscope. All of that fluid accumulation in the lungs can also lead to paroxysmal nocturnal dyspnea, which means at night the patient suffers attacks of shortness of breath to the point that the patient has to wake up, get out of bed, open the windows to get some fresh air. This is classic paroxysmal nocturnal dyspnea, a sign of left-sided heart disease. Moreover, the lungs are filled with fluid. This can lead to pulmonary edema. Check. Be specific, alveolar edema and or interstitial edema, and the pleural cavity will have pleural effusion. This increases the fluid in the lungs and therefore the pulmonary resistance. Who has to pump blood against all of this high resistance? The poor right ventricle. See, first you get pulmonary hypertension, then the fluid piles up on the right ventricle, eventually you get right ventricular enlargement, right ventricular hypertrophy. And when there is pulmonary hypertension, what's going to happen to the P2 component of the S2 heart sound? It gets loud AF. AF here does not stand for atrial fibrillation, although that is present as well in mitral stenosis. And as my right ventricle hypertrophies, guess what's going to happen? This will give me the parasternal lift, also known as the parasternal heave. Put your hand and palpate near the sternum and you will find something pushing your hand with vengeance. That's the parasternal heave, a sign of right ventricular hypertrophy. Who else is gonna explain to you mitral stenosis like this? Your professor with his PowerPoint? Give me a break. For the pros, notice the proximity between the aortic valve and the mitral valve, anatomically speaking. Oh yeah, they are near one another. Why should I care? Because this explains the Austin-Flint murmur. What is the Austin-Flint murmur? These patients have aortic regurgitation, and thanks to this rapid backflow of blood from the aorta to the left ventricle, this is gonna push on the leaflet of the mitral valve, making it narrower, functionally narrower, and you will hear a murmur that is similar, although not identical, to mitral stenosis murmur, even though the mitral valve is not organically pathologic. The mitral valve is not anatomically narrower than normal. It's just the backflow that is causing this effect. This is called the Austin-Flint murmur. When there is volume overload, the ventricle gets bigger. We call this eccentric hypertrophy. When there is pressure overload, the ventricle gets bigger. We call this concentric hypertrophy. And that's why in mitral stenosis we have right ventricular hypertrophy. What are the stages of mitral stenosis? We have stage A, stage B, stage C, and you will never imagine, stage D. Stage A, I'm just at risk of mitral stenosis. Stage B, I have progressive mitral stenosis. Stage C, I have asymptomatic severe mitral stenosis. It is severe, but I have no symptoms yet. Stage D, symptomatic severe mitral stenosis. And when the mitral stenosis is symptomatic and severe, you can bet the rent money that this patient will have atrial fibrillation. Not in 100% of cases, but in most cases. Never ever forget this. More on that later. Mitral stenosis is a narrow mitral valve, which means failure at opening. When is the mitral valve supposed to open? During diastole of the ventricle. And that's why mitral stenosis is a diastolic murmur. Usually it has an opening snap, alright, during diastole because it's diastolic. And then the opening snap is followed by a murmur that looks like this. It is low-pitched, which means low frequency. It is rumbling noise that ends with pre-systolic before systole accentuation, rising up until it ends up with a very loud S1 sound. So in mitral stenosis, not only the S1 is loud, but if it's complicated with pulmonary hypertension, the P2 of S2 is also loud. And instead of hearing the normal lub-dub, 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 you're gonna hear lub-drup, lub-drup. Where do we hear the mitral stenosis murmur? At the mitral area. Where is the mitral area? At the apex of the heart. Where is the apex of the heart? Left fifth intercostal space, mid-clavicular line, just half an inch below the patient's left nipple. Remember when we said in previous videos, you only need to remember this inappropriate word, which stands for aortic stenosis is systolic. And then, if you change one letter of these two letters, you flip the systolic once into diastolic. But if you change both letters, as in here, you flip it twice. Systolic to diastolic, and then diastolic to systolic again. So if we say that aortic stenosis is systolic, therefore, if I change one letter, which is the aortic, changes into mitral, therefore, you flip it once. You flip it 180 degrees from systolic to diastolic. If aortic stenosis is systolic, then mitral stenosis has to be diastolic. This is the mnemonic, but if you want to understand it, easy. Mitral stenosis is failure of the mitral valve to open. When is the mitral valve supposed to open? During diastole. Therefore, mitral stenosis is a diastolic murmur. Here is S1. Here is S2. Between S1 and S2, it is systole. Between S2 and the following S1, it is diastole. Where is mitral stenosis? Mitral stenosis is here. It is a diastolic murmur. First, there is the opening snap. Then there is the diastolic rumbling, low-pitched noise that ends with pre-systolic accentuation and a very loud S1. Where is the best position to hear mitral stenosis in? The left lateral decubitus position. Ask your patient to lie on his left side and then listen. The best moment to hear the mitral stenosis is immediately after the patient turns on his left side. How can I tell the difference between mild mitral stenosis and severe mitral stenosis? Well, we cannot tell from the duration of the murmur. Just because the murmur takes longer duration doesn't necessarily mean that it's more severe. However, you can tell about the severity of the stenosis of the mitral valve by the distance between S2 and the opening snap. The longer the distance, the less severe the stenosis. And the shorter the distance between S2 and opening snap, the more severe the stenosis of the mitral valve. Next, what's the effect of mitral stenosis on the pressure-volume loops? Here is the normal graph. Pressure is here, volume is here. That's why it's called pressure-volume loop. This rightmost line right here represents the left ventricular end diastolic volume, which is the volume in the left ventricle at the end of diastole. This leftmost line right here represents the end systolic volume, which is the volume in the left ventricle at the end of systole. Between the end diastolic volume and the end systolic volume, what is this? Stroke volume. Why? Because stroke volume equals end diastolic volume, this one, minus end systolic volume, this one. Now let's see what's going to happen in mitral stenosis. Since the mitral valve is narrow, less blood is going to flow from the left atrium to the left ventricle. Therefore, the volume of blood in the left ventricle at the end of diastole is going to be lower. And therefore, this line right here will be shifted more towards the left, i.e. lower volume. This was the normal volume. This is the lower volume seen in mitral stenosis. And if there is less blood coming to the left ventricle during diastole, less blood will be left at the left ventricle after systole, which means the end systolic volume will also be lower, i.e. shifted slightly to the left. How about the stroke volume? Notice the new stroke volume, it is slightly lower than normal. So in mitral stenosis, EDV goes down, ESV goes down, stroke volume goes down. But boy is the S1 loud. Boy is the P2 component of S2 loud. Next, the effect of mitral stenosis on these graphs that have time on the horizontal and blood pressure on the vertical. The green line represents the pressure in the left ventricle. In diastole, the pressure in the left ventricle is about 0, and in systole, it goes up to 120. How about the red line? It represents the aortic pressure. During systole, the systolic pressure is 120, and the diastolic is 80. And this is what you measure by the sphygmomanometer. When you say that the patient's blood pressure is 120 over 80, this is what you're measuring. The 120 on top, the 80 at the bottom. How about the left atrial pressure? Normally, the left atrial pressure should be about 5 over 0. So 5 systolic, 0 diastolic. It doesn't have to reach 5. It could be 3, it could be 4, no one cares. Look, as long as it's less than 12, we're good. But oh my goodness, look at what's going to happen to the left atrial pressure, the pink line, in mitral stenosis. Because the mitral valve is narrow, less blood is going to flow from the left atrium to the left ventricle during diastole of the ventricle. Therefore what? All of that blood will pile up in the left atrium. Therefore what? The pressure in the left atrium will rise from here to here. This rise in the left atrial pressure can also be called increased pulmonary capillary wedge pressure. I taught my student these shortcuts to keep it simple. The pressure in the left atrium is called pulmonary capillary wedge pressure, but the pressure in the right atrium is called the central venous pressure. Why do we call this the central venous pressure? Because the right atrium is the center of the big veins, including superior vena cava and inferior vena cava. It's as if the center of the venous system is in the right atrium, which makes sense. But why is the left atrial pressure called pulmonary capillary wedge pressure? Because the left atrium is connected to the pulmonary veins, which is connected to the pulmonary capillaries. Why is it called wedge pressure? Because the cardiologist is going to keep pushing the catheter, pushing the catheter, pushing the catheter until it gets stuck, i.e. wedged in the pulmonary capillaries. And that's when you measure the pressure. See, cardiology makes so much sense once you understand what the flip you're talking about. Here is everything you need to know about mitral stenosis in one amazing slide. Causes of mitral stenosis. Rheumatic fever is a common cause. Other less common causes include congenital defect in the mitral valve, ergot alkaloids, and calcification of the mitral valve. Mitral valve stenosis tends to be more common in females than males. Next, dyspnea or SOB, which stands for shortness of breath, because I'm a good guy, I do not curse. Paroxysmal nocturnal dyspnea. Orthopnea, sometimes even hemoptysis, because all of the fluid that accumulates in the lungs. Exercise intolerance, syncope. Why? Because there is less blood flow from left atrium to left ventricle, which means less blood will be ejected by the left ventricle, which means the cardiac output will be low, which means less blood will reach the brain, which means syncope or pre-syncope can happen. Next, if there is less cardiac output, there is less blood going to the coronary arteries that supply the heart itself. This can lead to chest pain. Fatigue due to decreased coronary blood flow. If there is severe mitral stenosis or long-term mitral stenosis, the radius decreases, resistance increases, the left atrium has to push harder, which gets us left atrial enlargement, which presses on the esophagus, causing dysphagia, compresses the left recurrent laryngeal nerve, causing dysphonia. Physical exam findings: the murmur. It has an opening snap followed by low-pitched diastolic rumbling murmur with a presystolic accentuation heard at the apex, ending with a very loud S1 sound. This is using the stethoscope. What if I use my hands? You can feel a thrill on the apex during diastole. And if we end up with pulmonary hypertension, you can find the parasternal heave or the parasternal lift. Next, something weird happens in mitral stenosis. My face turns pinkish purple. Not rash, but flush around the malar area. No one knows why this happens. Probably because of low cardiac output, meaning less blood is going to reach the face. If the left atrium is poor, blood is going to accumulate in the pulmonary veins, blood will accumulate in the lungs, and this will overwhelm the right ventricle, which will give me pulmonary hypertension, pulmonary edema, parasternal heave, loud P2, and because the fluid piles up in the left atrium, I have increased pulmonary capillary wedge pressure. If you are familiar with the neck vein waves A, C, X, V, and Y for the right atrium, the left atrium has similar ones. Prominent A wave and pulmonary capillary wedge pressure tracing is a sign of mitral stenosis because A stands for atrial kick or atrial contraction. When this left atrium is contracting, it has tons of blood, giving me a prominent A wave. In many cases of mitral stenosis, we have atrial fibrillation as well, which increases my risk of embolization, which can lead to an ischemic embolic stroke. If the clot ends up in my brain, but what if my clot ends up in the intestines? It can lead to mesenteric ischemia. What if the clot ends up in my arm? It's called acute limb ischemia. How do you diagnose mitral stenosis? Clinically, and whenever you hear a murmur with your stethoscope and it's a pathological murmur, then the next best step is to do an echocardiogram. Even better if you add Doppler to look at the flow. Echo will show you that the mitral valve is narrow. The Doppler will show you the abnormal flow because the flow from left atrium to left ventricle will be less than normal in cases of mitral stenosis. If you do an EKG, we can find signs of left atrial enlargement on EKG, signs of atrial fibrillation on EKG, signs of right ventricular enlargement on EKG if we have pulmonary hypertension. Chest X-ray will show you left atrial enlargement. How do I know that the left atrium is getting bigger? Look at this. Here's the left atrium here, and it's going to get bigger and bigger and bigger and bigger, which will cause straightening or flattening of the left cardiac border. If there is pulmonary edema, expect signs of syphilization on chest X-ray, as well as the curly B lines, among others. To learn about the chest X-ray signs seen in left-sided heart disease, please refer to my video on heart failure, which you can find here in this cardiology playlist. You can also do cardiac catheterization. How do you manage mitral stenosis? The non-pharmacological management includes physical activity and exercise. Medical management, anticoagulants, because the AFib increases risk of embolization thanks to the stasis. If there is AFib, ventricular rate control by beta blockers or calcium channel blockers. If we have symptoms of congestive heart failure, give loop diuretics to get rid of this edema. If rheumatic fever, give antibiotics. Next, surgical options for mitral stenosis treatment. We have valvotomy and we have replacement. You can try to repair the valve or you can replace it. Throw it in the trash and replace it with a new one. Let's start with repair or valvotomy. We have open surgical valvotomy, closed surgical valvotomy, and balloon mitral valvotomy. If you want to replace the valve, you can replace it with a tissue valve from another animal such as a pig or a mechanical valve, which is made of mostly metal. And if you have a metallic mechanical valve in your chest, I can actually know it just by listening to your chest because I will hear the metals slapping against one another. Let's review. Mitral stenosis, suspect AFib, which increases my risk of clots, dysphagia and dysphonia. Diagnosis is done via echo. Medical treatment is to reduce the preload, restrict salt, and give diuretics. If the patient is symptomatic despite maximal medical treatment, then we turn our attention to surgery. For the pros, Austin Flint murmur versus the murmur of mitral regurg that happens with hypertrophic obstructive cardiomyopathy. What is Austin Flint? This patient has aortic regurg. Thanks to the rapid backflow of blood, it compresses the leaflet of the mitral valve, making it narrower during this rapid flow, which will give me a murmur that is similar to, but not identical to, mitral stenosis. However, in hypertrophic obstructive cardiomyopathy, there is a big, thick, asymmetrical interventricular septum. This septum is relatively close to the mitral valve. It can grab the mitral valve and pull it away during its movement, making the mitral valve unable to close when it should, which causes mitral regurg. So, to recap, aortic regurg can give me a murmur similar to mitral stenosis, whereas HOCM can give me a murmur similar to mitral regurg. The following part is not for the faint of heart. What if I find advanced mitral stenosis, but there is no atrial fibrillation? Well, I should be very suspicious. Here is a true story from the famous textbook Sapira's The Art and Science of Bedside Diagnosis. Quote, Dr. Thomas Dorman of Kent, Washington, referred the patient for an immediate echocardiogram, asking the sonographer to look for an atrial myxoma. What? Why did the doctor order that? Why is the doctor suspicious of atrial myxoma? Here is why. Mitral stenosis develops gradually, whereas an atrial myxoma might grow quite rapidly. It is rare for a person with advanced mitral stenosis to be in sinus rhythm. Instead, we expect atrial fibrillation. The murmur did not have the classic mitral complex with the opening snap, presystolic accentuation ending with a very loud S1 sound. So, this doctor noted that the patient had severe mitral stenosis, but there is no atrial fibrillation. Moreover, the murmur of the mitral stenosis was a little weird. No opening snap, no presystolic accentuation, no loud S1. So the doctor said, oh, what else can lead to a murmur similar to that of mitral stenosis? Atrial myxoma is likely. Let's do an echo. And what did we find? Guess what? Atrial myxoma. And this, my friends, is the difference between a good doctor and a doofus with a stethoscope. Look around you. What do you see? Most doctors are frustrated mediocrities. I hope they contract tuberculosis. Just kidding. To learn about angina, myocardial infarction, strokes, cardiac arrhythmias, ARDS, acute limb ischemia, and more, download my emergency medicine high-yields course at medicosisperfectionalis.com. If you want to learn about cardiothoracic surgery, vascular surgery, trauma surgery, orthopedic surgery, neurosurgery, general surgery, and more, download my surgery high-yields course at medicosisperfectionalis.com. Beta blockers and calcium channel blockers can be used to manage atrial fibrillation. Do you want to learn more about these antiarrhythmics, the antihypertensives, the anti-anginal drugs, antihyperlipidemics, diuretics, and digoxin? Download my cardiac pharmacology course at medicosisperfectionalis.com. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.